Howdy, Aaron Boster here, live from New York City. I'm here for business over the weekend. I'm in a hotel room and I've been missing you guys, and I really wanted to jump online. It is awesome to join this online village. There's already some people that are showing up, and that's really, really cool. Hey guys, I hope you're doing well. I thought that we would get together tonight, and if you're interested, we could do an Ask Me Anything live question and answer about multiple sclerosis. So I'm going to give a few moments for some people to come on. This is the Ask Me Anything format. I ask that when you guys jump online, tell me where you're coming from. So tell me where you're writing in from. I love seeing this growing online global community. This growing village just fills my heart, and it's really, really awesome. Also, please keep in mind as you ask questions, two things. Number one, I can't diagnose or treat you on the interwebs. So please keep in mind that I can't answer a specific question about you unless I can examine you and look at your MRIs, et cetera, et cetera. You have to make sure that the questions are generalized. Hey, Tracy from West Virginia, hope you're doing well. And also, if you don't get to the question, if I don't get to your question, don't fret. I go through the post afterwards. I take screenshots of all the questions so that I can try to answer them in upcoming videos, so no sweat. Let's take a look and see who's joined us. I've got Stephanie. Hey, Stephanie, how are you doing? In steamy Columbus, Ohio. It is super hot this summer. I've got Linda from North Carolina. I've got Belle Gallo here from New York City as well. Thank you for inviting me to your city. Lucky Crowfeather is here from Portland, Oregon. Claire Rose, how are you doing? Hello, Aaron Bounds. Hello, Chris Cunningham. Hello, Timothy Bell. There's a lot of wonderful people jumping online. There's 67 of us that have come online so far, and I am looking forward to this Ask Me Anything. I thought I'd spend maybe an hour or so with you guys tonight before I turn in. I've got my water here, so of course we're going to play the water challenge game. When I drink, you drink, so get your water set up. One of our moderators, Matt, is online. How you doing, Matt? I've got Jamie jumping online. This global village is not something that I anticipated when I started to mess around with social media and with YouTube. I was really excited to share my videos, to share concepts about MS for people, but I never thought about the fact that there's this giant community growing bigger and bigger. We almost have 13,000 people on this community, and that's really, really neat. And I get a lot out of it. I greatly appreciate your input, your comments in my videos, the questions that you ask. Your willingness to share your own experiences is really absolutely superb. I've got Doug from Lyndhurst, Ohio. Doug, I don't know if you have coffee in hand right now, my friend, but I know that you will in the morning. There's people from Australia. That's always amazing to me. Australia is certainly on my bucket list. All right, so I've got the first question. This first question comes from Linda White. How long after your second half of Ocrevus until B cells are killed off? That's an excellent question. And so what Linda is talking about is this drug ocrelizumab or Ocrevus. I've got plenty of videos on the channel that talk about what Ocrevus is and how it works. It's an infused drug. It's given through an IV, and it's given once every 6 months. And the first dose we break in half. So we give you half of it, and then 2 weeks later we give you the other half. And what this drug does after the first 2 doses, it's given once every 6 months, just one slug. So to say that again, the first dose is broken in half, you give half of it, 2 weeks later the other half, and then every 6 months you give 1 dose. And as Linda points out in her question, what you're doing is you're murdering adult B cells. And so the way that we believe Ocrevus works is it identifies only adult B cells, not the stem cells and not the plasma cells, but the adult cells in the middle, and it kills them. And when you kill the adult B cells, that interferes with B cell T cell communication. And in doing so, you slow down MS, which is pretty awesome. Now, how quickly do you kill the cells? You kill them pretty quickly. When you look at the clinical trials, they didn't check daily. So they didn't give Ocrevus and check day 1, day 2, day 3. They checked out, and I don't remember if it was 2 or 4 weeks, but the kill rate's pretty quick. So you deplete your B cell population pretty fast. And as I've shared in other videos before, the reason that this drug is dosed every 6 months is because most people make back their B cells in 6 months. Those pluripotent stem cells grow up to become adult B cells in about 6 months. Now, in some people, particularly people that are a little bit larger in size, that may be 5 months. And at our center, we started to realize that for some people, we need to shorten the interval from 6 months to 5 months. Great question, Linda. Thank you for asking it. I see Stephanie writes in here about a blooper reel. And so Stephanie hit me up at one point to develop a blooper reel, and I did. And so Stephanie, fear not. Many of you might have seen a recent video that I put out just this past yesterday. And it's a video that I am super proud about, if I'm honest, and really excited about. It was my attempt at doing a comprehensive view of MS. It was 23 minutes long, which is maybe on the long side, and I'm sorry for that, but it is jam-packed full of information. And when I recorded it, Stephanie, I made a lot of errors. I'm talking like I had to do take after take after take to get it just right. So I saved all of my footage, and I am going to make you a blooper reel. It's probably going to be 3 or 4 minutes long. I'll throw it up on a video. Now, it won't do well in the analytics, but I don't care because I want to share it with you. So that'll come out sometime soon, and you'll see me doing take again and again and again and again. And I get a kick out of watching it because it's so embarrassing. So look forward to that. That's coming soon. Sandy writes in a question. This is Sandy Watson, and she says, question, Ocrevus. I have had my 2 half doses, and this was, she writes, in February. The first full dose is in August. Does Ocrevus affect teeth sensitivity? So she's asking about a side effect of teeth sensitivity, and I have not experienced any difficulties with teeth sensitivity using Ocrevus. Now, is it conceivable? I mean, anything's conceivable. And let me pose the question to the village. Villagers, anyone out there that has received Ocrevus, have you had any difficulties with teeth? Any teeth sensitivity? Please write a comment down in the section below and let us know yes or no whether you've noticed any teeth sensitivity. Sandy, we're going to throw this question to the village and ask if villagers reading this question who have been exposed to Ocrevus have had that experience. And I'd like to hear from you, Sandy, if you've had teeth sensitivity. Now, where I work at Ohio Health, we've treated a lot of people with Ocrevus, actually over 1,000 people. And I have not heard anyone talk about teeth sensitivity, but I'm not saying that it's not possible. That was a great question. So CPCP writes, you picked the wrong time to come to New York. It's so hot. I hope your room has good air conditioning. It does. I'm in a fantastic room. I don't even know where in the city I am. I'm a little embarrassed to tell you that, but I took a taxi down here. This is a great room, and it's got nice air conditioning in it. It is super hot outside. I'll tell you, CPCP, it's also really, really hot in Ohio, super hot in Ohio. On a live stream I did recently, you guys saw my chickens, and the chickens do not like the heat. We have a swimming pool for the chicken, like a little tiny swimming pool the chickens can get and move around in. And my wife even thought about putting a fan on them. It's so hot, they're not laying eggs right now, which is not okay because they are work animals, and the chickens are supposed to lay eggs. Now, here's a question from Beverly Swingle. Oh, where did the question go? Darn it. Sorry, guys. You know, I'm not, there it is. So there's a question, and Beverly writes in from San Diego. So hello in San Diego. And she writes, what time frame can one expect to have the maximum functional return that will occur after an exacerbation? And thanks, it's because of you that I'm in rehab with NeuroPT. Well, let's reverse the situation. First of all, I am super glad that you're doing NeuroPT. So good job to you. It makes me feel really good that maybe I had a hand in helping you get to that point. Neurophysical therapy is the bomb. It's really powerful stuff. Neurophysical therapists are expert physical therapists that did extra training to understand the nervous system. They understand MS. I have several neurophysical therapists that work at our center, and these women are brilliant minds. I learned a tremendous amount from working with them, and they can help our patients do phenomenal things. Think about this for a second. If you have MS, you have 2 reasons to become physically disabled. One reason is the progression of the MS. The second reason is deconditioning because of the MS. So my point here is MS makes it really hard to stay in shape. It makes it really hard to just go out and run. And as such, it's really hard to control your weight sometimes, or to stay physically active or physically fit, etc. And that's super frustrating. Neurophysical therapists are the key to figuring out how to beat that. They are really, really good at figuring out ways of helping people improve their gait mechanics and their balance and their strength and their core, and it's good stuff. So I am super thrilled, Beverly, that you're doing NeuroPT. Thank you very much for that. If you think of it after the NeuroPT, write in a comment and tell us what it was like. I'm sure that other people on the channel would really enjoy hearing about it. Now, the second part the question you asked was about the maximum return of function. And I can't answer that question directly because, in fact, it's different for every person. So there are situations where someone has an attack, and I'll use an example of optic neuritis. And you give them steroids, and the first or second day, poof, their vision has returned. And it's really fast. And sometimes you give someone a course of steroids, and within the next week, they get better. Sometimes you give someone a course of steroids, and they get better 8 weeks later or 10 weeks later. And I don't think that there's any clear-cut answer to this is when you see the maximal benefit. I do want to say a couple other things, though. In my experience in clinical practice, people are statistically less likely to respond as they get older. So I'm talking about chronologic age. So on average, when I treat a 20-something with steroids, they rebound quicker than if I give a 60-something steroids. And that is a generalization. It is not gospel. It's just a comment of something that I've seen in my own clinical practice. Now, does that mean that we shouldn't give a 60-something steroids? No, it doesn't mean that at all. It just means that there's maybe a less likelihood that they're going to have a response. The other thing that I would say to you is that I would expect return of function wherever we're going to get in about 6 months. And I wouldn't look for return of function from an attack after a year. And that's not a rule. That's just an observation and kind of a gestalt. So if you suffer an attack, and again, I'll use left eye, optic neuritis, and your vision is slow to come back, I'm still looking for improvements for that first 6 months. And after a year, whatever deficits we're left with, we're probably going to be left with. Now, there are exceptions, and I've seen exceptions, but I hope that answers your question, at least somewhat. So Timothy Bell writes in, have you dealt with veterans that have MS? I absolutely have. So I did my medical school at University of Cincinnati, which has a fantastic Veterans Administration hospital. And I saw veterans there, and I took care of some that had MS in med school, with supervision, of course. I did my residency at University of Michigan up in Ann Arbor. And Ann Arbor has a gigantic, really, really good VA hospital. And I worked a lot in that VA hospital. I took care of a lot of veterans. It was an honor to work there. I really liked it. Taking care of veterans is really cool. And yes, I took care of some guys and gals that had MS. During my fellowship at Wayne State University, there was a veterans hospital, and they didn't do a lot of MS care at that veterans hospital. They actually gave them a dispensation to come to our center, which was like just down the street, and we would see them there. I work in Columbus, Ohio, and Columbus is a small Veterans Administration hospital. And a lot of the vets are allowed to come see us. And so there's an organization, because they don't have MS specialty in Columbus, Ohio, at the VA hospital, they allow them to come and see us. And so it works out really nicely. I love taking care of veterans. It's an honor. And so, yes, I certainly have. Thank you for the question. So Debbie writes, can you be infused with Tysabri if you're on an antibiotic? And so the answer is you could be, but I wouldn't. Why do I say that? Tysabri, which is a great medicine for MS, it's infused through the vein, and it's given on average every 28 to 42 days, so every 4 to 6 weeks. And when you give Tysabri, you need to continually give it so it creates this barrier, because Tysabri creates the Great Wall of China where no cells get through from the bloodstream into the central compartment. The blood-brain barrier becomes super, super tight so those cells can't cross. And you have to keep redosing it to maintain that barrier. And you have to keep in mind the time frame. We typically give the drug, as I just mentioned, every 4 to 6 weeks. But you can go out as far as 8 weeks on 1 or 2 occasions without unbinding your receptors, without breaking down the Great Wall of China. So if you are 4 weeks and it's time to receive Tysabri and you have a urinary tract infection and we're giving you antibiotics, at my center, we just wait a week. It does not hurt the person to wait that week. It doesn't increase the risk of an attack. It doesn't put them at increased risk of something else. And given that we have this wiggle room, I don't want to interfere with the antibiotics with the Tysabri. So it's my practice that I would just punt. I would just have you come back the following week. That's not gospel. You could technically do it, but I wouldn't want to because I don't want to risk interfering. So that's my 2 cents. That's what we do at our center. We infuse a lot of Tysabri. Tysabri is a great drug. The flexibility of needing to give it somewhere between 4 and 8 weeks gives us a month that we can finish the antibiotics and jump back in. So let's look at another question. Dre Sandoval. Sorry if I said that wrong, Drea. Sandoval writes, have you ever used methotrexate to treat MS? Great question. Now, Drea, I would be curious where you're writing in from, because methotrexate or Imuran are medicines that are maybe used more often in Europe than in the United States. Methotrexate is an oral immunosuppressant. It's a pill. It's typically given once a week. And it suppresses the immune response. And it does it sort of in a global fashion. So it's not targeted. It's not specifically hitting a cell. It's kind of crushing everything. And methotrexate is used very frequently in rheumatoid arthritis and lupus and other connective tissue and other autoimmune conditions. There is a literature that looks at the effect of methotrexate. This is an old paper, I think in the 80s, and it demonstrated in a very, very small trial that it might help with arm function. We do not generally give methotrexate to treat MS simply because the modern therapies are better. So the modern therapies, the monoclonal antibodies, for example, that I'm fond of using, or the oral agents that are moderately effective. These are, when I say oral agents, I mean the MS drugs like Gilenya, Cladribine, Tecfidera, Aubagio are probably more effective, and there's certainly more data. So yes, one could use methotrexate, but it's not something done in clinical practice very often. Also, for people that like to use Tysabri, if you give someone an immunosuppressant, and methotrexate is an immunosuppressant, it would increase the risk of PML if they were to become JC virus antibody positive. So being JC virus antibody positive and having prior immunosuppression really increases the risk times 4. And so I would probably not opt to start there in case I down the road wanted to use some Tysabri. That's just my 2 cents. I will share that I have a patient that I'm taking care of, and they're on an MS medicine and infused medicine, and they also have a rheumatologic condition. And in working with their rheumatologist, we've agreed to add methotrexate. Now that's off-label. I am not recommending that you do that. I'm simply sharing that I practice medicine in the real world, and in the real world, sometimes nature's too generous, and you can have MS and lupus, and so we have to do more than one thing. And so, you know, that's the situation that we found ourselves in with this particular patient, and that's how we gamed out making it better, by adding on that methotrexate. Let's take a look at some other questions here. Kathy Riggs writes in. Hey, Kathy, how are you? Will brain lesions or brain black holes ever heal? So I have several videos on the channel focused on the MRI. I have a video called Black Holes and Atrophy. So if you would like to have a deeper dive, check out on this channel under the MRI playlist. You can find some videos on that. But to talk about it briefly, the term black hole, and I don't know how to, I wish I was more savvy with computers. I'd throw up an image, but I certainly have them in the video that I made. A black hole is what it sounds like. It's a hole. And when you're looking at the MRI, there'll literally be a black circle. And that black circle is a hole. There's a lack of brain tissue there. And it's because of one of 2 things. So follow me here. When you have an acute MS attack, like it happened right now, and you have a new white spot on your MRI, that's on the T2 sequence. But on the same MRI, if you look at the T1 sequence, which is a different set of images obtained during the same MRI, you'll see there's a black spot, which will line up with the white spot. So they'll overlap. That black spot during an acute attack, the black spot represents edema or swelling. It's fluid. And sometimes when the attack resolves and the swelling goes down, that black spot goes away. So if you got an MRI and you saw a new white spot with a black spot, And then you look like, say, a couple months later, you might not see the black spot. And that black hole is an acute black hole, and it went away. If the black hole is still there, and the definition I use is 9 months. So if 9 months later, the black hole is still there, now we don't think it's edema or swelling or fluid anymore. Now we think it's literally a hole. And in fact, the darkness of the hole, the blackness, the black color, the more black it is, the less tissue is left. So the normal color on the MRI is that gray color, and the darker it gets, the less axons, less neurons are there. And a chronic black hole doesn't heal itself. This is literally a hole. It's brain damage. And sometimes people get upset with me when I talk about brain damage, but you guys know I do that for a reason. I think doctors hide behind words sometimes. We talk about a lesion. Well, what's a lesion? A lesion is brain damage. Or we talk about an MRI spot. And that sounds like it's not a big deal, but it's a very big deal, because we're talking about damage to the holiest of holies, the supercomputer that runs the body, the brain. And so that's why I use the word brain damage, because it is brain damage. And I want to call it what it is in a way that you understand what I'm talking about. If I say, oh, you have a new spot, you might say, okay, well, I have a new spot. And if I say you have a new spot on your brains, okay, I have a spot on my brain. But if I tell you that you have new brain damage, I think that resonates more with the reality of what's going on. That was a great question, and thank you for asking it. So Tracy from West Virginia writes in a follow-up question to Linda's question. Tracy says, are there any labs our clinicians should be doing 4 weeks or so after the second half of Ocrevus to check the B cell levels? That's a very good question. The answer is no. There's a drug, another drug that works very similar to Ocrevus, a drug called rituximab. They both kill B cells. And I used rituximab for a very long time, off-label, before Ocrevus was available. And in fact, there was a clinical trial called the Olympus trial. And the Olympus trial looked at primary progressive MS, and they gave people Rituxan every 6 months. And at 6 weeks after the dosing, we checked B cells as part of the clinical trial, the Olympus trial. And we checked them at 6 weeks to make sure that the B cells were depleted. And then we would check it at 6 months. That was the way the trial was constructed. And then when I started to use Rituxan off-label in my MS patients, I just did what I did in the trial. So I would give Rituxan, and then 6 weeks later, I would check for B cells. They were always zero, always. They had always depleted. I never, ever saw that they were ever anything but zero. So I stopped checking because it's a very expensive lab test, and it was never abnormal. It was always zero. And so it was a waste of people's resources and money. And so with Ocrevus, we know we deplete the B cells. And so I don't feel like it's appropriate to check at 4 weeks to prove that they're depleted. I just think that would be expensive, but it wouldn't change management. And Tracy, I don't like to order tests that don't change things that we do. So I don't want to order a test and be like, the tests that we order, they're expensive. It's invasive. I have to poke you with a needle. And so I want that test to change what we do. Now, there's 126 people online. I think that's really cool. Thank you, guys. There's 43 thumbs up. If you like this format, if you enjoy this Ask Me Anything format, do me a favor and give me a thumbs up. And so I think you actually have to close out of the live chat, click thumbs up, then jump back in. Hopefully the moderators can help you with that, because I don't really exactly know. But if you're digging what we're doing, throw a thumbs up there. That makes me feel great. So let's look for some more questions. This is a comment from Ren E. Berry. So Ren E. Berry writes, comment, I ignored right arm weakness and pain, thinking it was due to MS. MRI showed a rotator cuff tear. So, Ren E. Berry brings up a really good point. You don't get a buy from the rest of life just because you have MS. Now, I think you should, but you don't. And so you can have MS and a rotator cuff tear. I'll use a different example. You can have a herniated disc in your neck, which is pushing on your spinal cord and causing your legs to go numb. And if you have MS, you might assume that's an MS attack. And it's not. It's coming from a disc pushing on your neck. So it's important that people with MS and clinicians taking care of people with MS remember that, because you don't get a buy from the rest of life. And we have to treat the human being, not just the disease. And you give a good example of that. So thank you for sharing. So Shell Z, hello Shell Z, writes in, can you talk about IgM and Ocrevus? My original dose, I was still low prior to dose. This time, I was in the normal range. Can you talk about how neurologists interpret IgM with Ocrevus? Okay, sure. So for starters, IG, and I'll type this in here for you guys. Ig equals an antibody. So an Ig stands for immunoglobulin. So immunoglobulin is the doctor term for antibody. So when you see Ig, it means immunoglobulin. It's an antibody. And then there's different kinds of antibodies. There are IgM, IgG, IgE, IgA. There's a bunch of Igs. IgM is the antibody which you see when there's an acute infection, like an infection today. So if I got EBV infection today, so mono, and you drew my blood and you looked at the antibodies, the IgM level against EBV, the virus, you'd see that it was really high because I'm currently infected. Now, when I clear the infection, the IgM goes down, but the IgG is the antibody that remembers. So I keep IgG in my body. Now, so I'm just sharing that with you so you know what Shell Z is saying when she asks about Ig. So Ig means antibody. And IgM are the acute antibodies. I don't mean cute like you're pretty. I mean acute like quickly, like now. And when you give people Ocrevus, most of them, it doesn't affect their antibody levels. And that's because the cells that make antibodies aren't really affected. But rarely, and I don't remember the number, I think it's like 11% or I don't remember the number, but it's a low number. Rarely, people can have a drop in their IgM levels. And most of the time, when they drop their IgM levels, it doesn't matter. It has no clinical bearing. Rarely, that's two rarelys, rarely you drop your IgM level and those people have an increased risk of infection. And so this is information which has made it into the European label, but not the American label. And it will probably make it into the American label. So what do we do with that? How do we act about that? Well, let me tell you. In my clinic, at least, if you're on any drug, but if you're on Ocrevus and you're having recurrent infections, I'm not okay with that. And you're not okay with that. And so if you have recurrent infections, we may choose to come off Ocrevus and do a different drug. Or if we really don't want to come off Ocrevus and we're thinking about switching, maybe we'll check Ig levels, so antibody levels. And if you're having lots of infections and your Ig levels are low, now together that is enough evidence for me to say, maybe we should do something different. Now, most neurologists don't do much with antibodies. I am a MS neurologist or a neuroimmunologist. I deal with the interface of the nervous system and the immune system, kind of where they connect or where they intersect. And as a result, I do more with antibody testing than maybe the next guy. And so I hope that answers your question. So here's a question from Lovingdale. Hello, Lovingdale. Question: I am newly diagnosed-ish, in the process anyway. If I plan to become pregnant within a few years, would it be okay if I choose a DMT on the more effective side, such as Lemtrada? Great question. Now, Lovingdale, thank you for the question. Thank you for all of your participation. I love when you're on these live streams. You always ask great questions. And I have I have a video on this channel about pregnancy. So if you haven't seen that video, I would most certainly ask you to check out that video because I talk a lot about pregnancy. Now, if you're not planning on getting pregnant for a couple of years, then I think it is on, and I would be on the most effective drug that you're comfortable with, because we want to control your disease so that you can be the best mom possible, so that you don't accrue neurological damage and brain damage and disability, which would impact your ability to be a great mom. And specifically, as it relates to your question of Lemtrada is interesting. I've talked about this before, and I'll share it with you now. Lemtrada leaves the body in 1 month. So when you infuse the drug Lemtrada in your arm, it's biologically active. It's inside you for 1 month, and then it leaves. And if you look at the American label for Lemtrada, by month 4, it's safe to get pregnant, which is a very unusual situation because you're still being treated. The effects on Lemtrada last years. So think about this. You get treated with Lemtrada, and then after you're done being treated with Lemtrada, you're not actually receiving a therapy, which means it's safe to become pregnant. and yet you're still being covered for your MS. And so that's a very unique and specific situation. But even if we don't talk about Lemtrada, even if you talk about another highly effective drug, Tysabri, Ocrevus, something like that, I still think it's a really good idea. If you know that you're not going to get pregnant for a couple of years, we have time. And during that time, I want to get your disease quiet. I ask my patients if we can have a year of disease stability, a year of disease quiet prior to trying to become pregnant. And so I hope that helps answer your question, Lovingdale, and certainly check out that video if you haven't seen it already, the one I did on pregnancy. So Sandra Watson writes in and says, question, which is helpful. If you guys write the word question, it helps me find that you're asking a question. So put it in bold, say question. Question, she writes, the blood work drawn prior to Ocrevus is for what reason? What are neurologists looking for? That's a very appropriate question. And I would encourage all of you, any of you that receive blood tests, ask why. Why are you drawing this? What's it for? And I think it's appropriate to ask for copies at your next clinic visit. Say, can I see my results? And so before you start Ocrevus, you want to make sure that the person doesn't have any infections that would be worsened by the Ocrevus. So at my center, we like to test for tuberculosis because I wouldn't want to give you a B-cell killer if I knew you had tuberculosis. So I check. The other thing, which is actually in the label, is to check for hepatitis, and particularly latent hepatitis B. Now, hear me out. There's never been a case of hepatitis B reactivating when you give Ocrevus, but there has been cases of hepatitis B reactivating with another B-cell agent called rituximab or Rituxan. So because we've seen it with Rituxan, the manufacturer, when they wrote the label, they said, well, we should probably use the same logic with Ocrevus. So before you take Ocrevus, we want to check your blood to see if you've ever been exposed to the hepatitis infection, hepatitis B in specific. And if you have, and you've cleared it from your body, there's a risk, theoretical risk, that it could reactivate if you took Ocrevus. So what do we do if somebody's been exposed to hepatitis B? Well, I send them to a hepatologist. A hepatologist is an internal medicine doctor who specializes in GI, in the gut, who further specializes in the liver. So hep means liver, so hepatologist is a liver specialist. And I ask them what they think, and they do some testing. And thus far, all the time I've done that, they've come back and said, green light, go ahead and give it to them. But that's what we're testing for, typically. And other doctors may test for other things, but those are the things that I test for. Looking for more questions, there's a question from Cheryl Vander Linden. So hello, Cheryl. Cheryl writes in, question, do you recommend MRIs with contrast on post-Lemtrada MRIs? That's a good question. I'm doing the MS Water Challenge. Are you guys drinking when I'm drinking? So if you want to do the MS Water Challenge, when I drink, you drink. And I like to get contrast when I get an MRI. I did a video on that specific question, should we give contrast? So if you look in my channel, there's a video I did on giving contrast, the contrast agent. I want to give contrast. I learn more when I give contrast. Contrast being present or absent can help clarify diagnosis, and it can help clarify breakthrough disease activity. Now, if you don't give contrast, it's not like the MRI is dumb or useless. You just don't learn as much. And I would submit that maybe like 80% of the information you want to learn, you can learn without contrast. But there is some information that you lose if you don't give contrast. So it's my preference to always do an MRI with or without contrast, unless there's a reason why we can't. So one reason why we can't is if the person has bad kidneys, because the contrast agent is cleared through the kidneys. So if you have kidney disease and I give you contrast, I could hurt your kidneys. So that's a situation where you wouldn't want to. Now, some patients are scared of contrast. And there's an old type of contrast, linear molecules, which can be deposed in the brain. It can get stuck in your head. And we don't use those. At my center, we only use macrocyclic molecules, and these are impossible to keep in the brain. They all get cleared out. You don't sequester any of them. There's no deposition. And so there's zero concern that it's going to be deposed in the brain. And so that being said, if a patient says, "Doc, I'm scared, I don't want contrast," well, I don't argue with them. We just don't give them contrast because it's their body and it's their brain and they have the right. I simply tell them I don't learn as much information. So I may not be able to make as informed decisions for you or with you looking at your MRI. And for some people, that's okay with them. Now, you ask a question about post-Lemtrada, and I don't think it matters what disease-modifying therapy we're talking about. I like to get an MRI 6 months after the second dose of Lemtrada. That's when I like to get an MRI, and I want to get it with contrast given the opportunity. So I hope that answers your question, and definitely check out the video on the channel where I talk about MRI and contrast. So Regina Ferguson wrote, "I'm having it now, the sensitivity." And I assume she's talking about the teeth sensitivity that we brought up earlier. Sandy Watson says, "Thank you, Village." This is a really cool village, Sandy, don't you think? It's amazing. There's 122 people from around the globe online. It's 10:42 in the evening on a Friday, and I am just overwhelmed with emotion, and I want to thank all of you. Thank you, thank you, thank you. Very, very cool. Mwah. It's super awesome that we can all get together, and I love getting a chance to talk to you guys. So I hope you're enjoying this. There's 95 thumbs up. That's a good sign. Let's keep going and answer some more questions. So Cheryl Z says, Ocrevus and teeth sensitivity. Yes, that's interesting. I have not heard that. Aaron Bounds writes, "Can you give me some advice?" No, wait, I lost the, darn it. Sorry, sometimes the feed jumps and then I lose where I am. Scrolling back. Looking back, trying to find the question. Cheryl, I'm really sorry. I can't find where your question is. All right, I'm sorry. I'll have to find it later. It's not that I didn't want to answer you. I just can't find it. All right. So Beverly Swingle asked another question. She writes, "I'm the one on Rituxan. It's pretty similar to Ocrevus. How often do you do MRIs on your patients on Ocrevus?" Well, I do MRIs in people with MS every year until about age 60. And when I start a drug, I like to get an MRI before I start the drug so I know where I'm starting. And then I like to get an MRI about 6 months after I start a drug, which I call the rebaseline MRI. Then I do it once a year. And if you have to switch drugs, I repeat what I just said. Otherwise, I'm imaging you about once a year. Now, after the age of 60, we'll discuss whether we do it once a year or once every 2 years. So that's what I do in my clinic. And that's true for any drug, not just Ocrevus. So Brenda Douglas writes, "I was on Gilenya for only 2 weeks because it was causing an AV block. How long should I wait before we number 7 Aubagio?" And what I think she means is before we start Aubagio. So I can't give you advice for you because I don't know you and I don't know the details. But there's a couple things we have to keep in mind. If you've only been on Gilenya for 2 weeks, that's not very long. And that's not enough time to bind up all your receptors. And so probably 2 weeks later, you're going to have cleared all the Gilenya. But you can check because you can draw a white blood cell count and look at the lymphocytes. So it's called the absolute lymphocyte count, or ALC. And if the ALC has gone up back to normal or close to normal or above 0.8, well, then most of the Gilenya effect, as we understand it, has left. And so there's a way to figure that out. And you definitely want to do that with your doctor. I probably would just go ahead and switch you. But again, I don't have enough information to be able to answer specifically for you. Definitely something to talk to your doctor about. So Melanie says, please X out of the live chat and give him a thumbs up. Melanie, thank you for that suggestion. And if you guys dig what we're doing, definitely give it a thumbs up. Let's see what else we've got cooking here. Sandra Young writes in, "Hello, Sandra. What causes severe pain at the base of the brain? It's not constant, but it happens a few times a week. Yuck." So there's a lot of things that can cause pain at the base of the brain. You can have a musculoskeletal problem. You can have low-hanging tonsils in the brain. You can have a migraine headache. You can actually have an occipital neuralgia. So there's a nerve back there. You can have pain from the neck, which radiates and presents back there. There's a multitude of things that can cause pain back there. And it's something that we have to sort out based on what we learn from the history, the physical exam. Sometimes we need to do some imaging. When we have an occipital neuralgia, when there's pain right there, I sometimes will refer patients to get an injection. And it's a little tiny injection right there. It's a small needle they inject with some numbing medicine and steroid. And when it works, it's awesome. It blocks the occipital nerve and the pain goes away. And so that's really cool when that happens. AJHR has jumped online. Hello, AJHR. One of our wonderful moderators writes, "Hey, Dr. B, glad to see you. It's always glad to see you. Thank you for being here." And I thank everybody for being here. MS in the 11th percentile's on. She's absolutely wonderful. She has a great YouTube channel. I've been putting out some really cool content. So if you guys haven't checked her out, you should certainly do that. So I've got Dina Perry who writes in, "What is IVIG and why does it help me when I go to the hospital?" So IV is the route of administration, intravenous. That's what the IV stands for. So I'll write this down. IV is intravenous, right? So IG, remember we talked about that earlier, is immunoglobulin, which is an antibody. So IVIG is a bag of a bunch of other people's antibodies, for real. What they do is when you donate blood, they separate the blood into all the different parts, the red blood cells, and they also separate out the antibodies. And they clean it, and then they collect it from like thousands of people, and they stick it in a bag. And that's an IVIG bag. And then they run the antibodies into your arm in through the vein. And because you have literally hundreds of thousands of antibodies, some of those antibodies will bind to your autoantibodies. So if you're having an MS attack, again, I'll use an example of optic neuritis, some of what's going on is your naughty autoreactive antibodies are attacking this area. So I'll use a cartoon of this is an antibody, and here's the IVIG antibody, and they bind, and they no longer function. So this is a non-functional antibody-antibody complex, and it falls out of solution. So it's a way of clearing out naughty autoantibodies by giving someone IVIG. IVIG treats MS. It can treat attacks. It can slow MS by giving routinely. It's extremely expensive to give. And the reason it's expensive is you can't make it. You have to collect it from people. So very, very hard to get. Very, very expensive. All right, what else is cooking here? I've got Michael Murphy online. Hello, Michael. Says, "Good evening, doctor." It's Michael from Sarasota, Florida. "I've been on Aubagio for 1 year with no side effects at all." That's fantastic. I like Aubagio. Aubagio is not a highly effective medicine. It's not a drug that I choose to start when you're newly diagnosed or when you're young. But I think that we want to keep treating people even when they're in their 50s, 60s, 70s. And so I like to use Aubagio in the second half of the disease. And I like it because it's very, very well tolerated. It's super well tolerated, and I think that it's very safe. And so I think it's an excellent drug. It's a once-a-day pill. I'm super glad that you're on Aubagio. I'm glad that you're tolerating it. I think it's really great. What else do we have cooking here? So this is one I'm not familiar with. Marianne Floyd writes, "What are your thoughts about grounding mats, earthing for MS?" I have to be honest with you, Marianne. I don't know what that is. So I apologize, but I'm not sure what that means. And so I'm going to have to Google it later. And maybe next time we get together online, I can answer your question. Sorry. So here's a question from Dax, and I'm going to try to say Dax's last name. Mascarenas. So Dax, I hope I said your last name okay. It says, question, is there much difference between Lemtrada and Tysabri? Yes. There's a lot of differences. Now, both of them are drugs. Both of them are monoclonal antibodies. So they're engineered antibodies in a laboratory. Both of them are intravenous, given through the vein. Both of them are highly effective. And everything else is different. Tysabri works by creating the Great Wall of China so that no cells can get through. Lemtrada works by reprogramming the cells, by killing the adults and building back the young guns differently. Now, I recently have a video on this channel. So Dax, if you look back through my recent videos, and I think it's called Highly Effective Drugs, Tysabri, Ocrevus, Lemtrada, Oh My. It's actually from a live stream I did on the topic, and then I spliced it all together and edited it. I made a little video. And so I would encourage you to watch that video, because in that video, I explain in some detail exactly how these drugs work, and I kind of compare and contrast them a little bit. So check them out. Hopefully that answered your question. Now, here's a question from Bella Gallo. So Bella writes in, question, is there a way to flush Ocrevus from the body if the side effects are bad? And my answer is, I think so. We had one situation where we had to get Ocrevus off someone's body, and we did plasma exchange or plasmapheresis, and it pulled the Ocrevus off their body. So there is a way to do it. It's very, very involved. It's invasive. It's expensive. But if you really had to, you could do that. Alternatively, you could wait 6 months or 4.5 months, because the drug Ocrevus stays in your body for about 4.5 months, and then it's cleared. And so if you waited it out, you would also clear it. So those are the options. Now I've got a question from MS in the 11th percentile, who I adore. Hope you're doing well. Which blood tests can be affected by high-dose biotin? I just had multiple panels and nothing came back weird. Should I still go off for a week and get checked? Yes. So what she's talking about is the vitamin B7, biotin. So the vitamin B7 biotin is sold in health food stores over the counter to improve your nail quality in your hair. And if you guys look at this male pattern baldness, I am not using any biotin. But biotin at 300 milligrams, not 3, but 300, which is a really big dose, has been shown in 2 provocatively cool clinical trials to slow multiple sclerosis, specifically to slow brain volume loss and to slow disability in primary progressive MS. Now, there's a trial going on right now which is trying to study this at a very high level. And so that trial, I think it's done to enrollment, and we should see results in the next year or 2. But I will, on occasion, recommend that someone take high-dose biotin. But please listen to the following couple sentences. This is important. If you take ultra-high-dose biotin, it can change certain lab results. And so my recommendation is a week before you go to the doctor or a week before you have a lab, stop the biotin. In reality, you should be able to clear it in 3 days, but I ask for people to do a week, and that way we know it's out of your system. Specifically, the labs include thyroid labs, labs to test for heart attacks can be changed. Hepatitis labs can be changed. And there's several others. And you might say, well, why? It's actually kind of interesting. When you test blood, you're doing an experiment. Not like for the first time, but you're taking the blood sample and you're putting it into some type of machine, excuse me, or some type of gizmo to study what's in it. And it turns out that some tests, the physical test, uses biotin. They use biotin as part of the test. And so if your blood is full of biotin and then you get a test, it can mess up the results. It's not that there's a problem with your thyroid, it's that the biotin in your blood goofed up the way the test works. And that's why we want you to. So in this particular instance, everything looked okay, but I don't want anything that's going to potentially interfere with the interpretation of the results. So I would stop it, wait a week or at least 3 days, and then I would check it again. And that's just my 2 cents. Sorry, guys. It was a long week and a stiff neck. All right, what else do we have going on here? Okay, here's a question. Kimberly asks, how do we successfully manage hypothermia or low blood temp, and why does it occur? Much emphasis on regulating high temp. What if we struggle with low temperatures? So Kimberly brings up the fact that there are centers in the brain that control your temperature. And I would say at least 3 times in my career, I've seen a person with MS have a really low temperature. You know, we're talking like insanely low. Like you check their temperature and it's like the high 80s. And it should be in the mid 90s. And I'll share that it's really hard to treat. I have not been successful in coming up with a clever way of trying to keep the person to bring their temperature up. There is a part of the brain called the hypothalamus, So the hypothalamus is kind of like the temperature gauge in your brain. And the theory is that that part of the brain takes damage, and then it changes the set point of the temperature, and that can cause low temperature. It is described in medical literature. It is something that I've seen on at least 3 occasions. It's something that's I'm not clear on how to fix it or how to treat it. And what we've done is we've tried to externally warm the patients, and that at least helped them feel better. So Melanie is telling Dax that he, which is me, did a great video last week on Tysabri, Ocrevus, Lentrada. Melanie, thank you for that. And if you guys haven't checked that video out, please do. So Deborah Pines writes in, question, is it appropriate for an MS specialist to recommend not using a DMT after age 50? I was told MS isn't very active after 50. Whew. So let me take a deep breath so that I don't yell and scream. Okay, I'm very calm. No, that's not okay. That actually makes me upset. I am of the belief that you still have an immune system. 50 is not old. And I think that we are risking taking people off therapy and allowing them to accrue brain damage and allowing them to accrue disability. And so I am of the strong opinion that it's really not a good idea to stop someone's drug after the age of 50. There are MS specialists around the country where it's becoming like a fad, like wearing your hat backwards is a fad, and it's a fad to stop drug because the disease is less active. And I think, if I may, that's bullshit. Maybe people who are 50 have less attacks, but they can have disability. And these drugs do more than just stop attacks. They stop brain damage. They slow down the rate of brain volume loss. They help delay disability progression. They help manage fatigue. So I do not think personally that it's okay to stop. I really, really don't. And I have a video on the channel where I said, is it okay to stop after 60? And my answer is no, it's not okay. I think that it is a plague upon our field, that there are some doctors out there that are promoting this concept. They're studying it. There was a paper that came out that said if you took a bunch of people that had not had attacks in 5 years and they were over 55 and you took them off their drug, only 1/3 went on to progress. What? 1/3 of people progressing is a lot of people. And if that 1/3 was my family member, I would be pissed off. And so I am not endorsing stopping medicines at age 50. That's my 2 cents, but you're listening to my live stream, so I'm allowed to share my opinion. All right, let's see what other questions we have going on here. Before I answer other questions, let me just share a thought that I had with you. I had a patient this week make a comment to my team. They were mad because I couldn't see them quick enough. And they were upset by that. And they wanted to get a quick appointment with me. And we were able to get them in to see a nurse practitioner, but that wasn't okay with them. And they said something to my staff that my staff didn't share with me. And they said, well, if he didn't do so many damn videos, he'd have more time to see patients, which made me sad and made me upset because I'm a doctor. That's what I do for a living. I go to clinic and I see patients. And I start clinic at 7:30 in the morning, and I see patients until 5:30 or 6 p.m. at night, and I'm in clinic 3 days a week. And I oftentimes add patients on my administrative days. So I have an administrative job as well as part of the hospital system where I work, and I will fit patients in on Thursdays and Fridays, and I will very routinely see patients after hours if I have to. I don't make YouTube videos while I'm in clinic at work, and I don't make YouTube videos when I'm doing my job as an administrator. I make YouTube videos when other people hang out with their friends or when other people hang out with their family. This is my free time. So I'm in New York City right now. It is 11 o'clock. I didn't get a chance to travel with my family. I'm here for work, and I could be out in New York gallivanting and running around and seeing shows or going to bars, and I'm not doing that. What I want to do is I want to spend time with you, and I want to spend time with Global Village. And it's the same thing when I make a video. I make a video because I want to share education and information. I want to empower people. I want to educate people, and I want to energize people impacted by MS. It's something that's really important to me, and I'm doing it on my own time. So I really didn't like that comment very much. Someone said, well, if you didn't make so many damn videos, you'd have more time for patients. Well, that would be true if I saw patients at 1 o'clock in the morning when I'm making videos, or at noon on Saturday. And so I don't know. I just want to share that with you guys, and I would be curious about your comments. It's something. This is not my daytime job. I'm not making money doing this. I'm doing this because I think that YouTube is a really cool way of sharing medical education, and I want to up your game. If I see a patient 4 times a year, or twice a year, 3 times a year, which is about 3 to 4 times is about how often we see people at our center. That's a couple times a year. That's not very often. And they have MS all the time. And so I've been trying to figure out, how do I help educate them? How do I help raise their level of understanding, which in turn makes them able to manage their disease better if I only see them like 3 or 4 times a year? Well, one way is I can do patient programs. So if a pharma company gives me an opportunity, I like doing patient programs. I really enjoy talking to groups of patients. I get to talk about MS. I get to educate them about MS disease medicines. That's good stuff. But I can't do it often enough. I do CMEs, or I'll do education programs with MS Views and News, and with other organizations, MS Foundation, MS Association of America, MS Society. I do patient programs for all these groups, and I love doing them. But those are each like once or twice a year, and it's a local audience, and it's not broadcast live, and so I can't reach very many people. There are almost 13,000 people that have subscribed to this channel, which is amazing. And it's a really cool forum for me to be able to help educate you. But it's not in place of what I do for my job. My job is I'm an MS doctor. And I don't understand why sometimes people confuse that. So thanks for letting me get that off my chest. It's not my goal to be difficult or adversarial. It's my goal to bring you cutting edge information and tricks and tips to up your game and make you more awesome, and to educate you about this condition so that you can beat the pants off of it. That's what this is for. And I guess at the end of the day, if somebody doesn't like that, then they don't need to watch my videos. All right. Sorry for the rant. So John L. writes a question and says, which of the effective medicines are best at slowing brain volume loss? I think the top 2 medicines to slow brain volume loss, in my opinion, are Ocrevus and Lemtrada. And not in any particular order. I think they're both really good at slowing brain volume loss. There are many other drugs that slow brain volume loss. Aubagio does a very good job of it. I think Gilenya does a very good job of it. I think cladribine can do it. So there's plenty of drugs that can. But I think amongst the best are the first 2 that I listed. All right. What else do we have going on here? Let's do 1 or 2 more questions, and then we'll wrap it up. So Aaron Bounds writes, tell that patient that most neurologists are dry and have no bedside manners. I only have found 2 neurologists in my diagnosis life that actually care. You and one doctor I had in Mobile, Alabama. Well, Aaron, that's very nice of you to say. Thanks. It's interesting. So you go to med school and you learn all this stuff. And if you can't convey that stuff to another human being, it kind of doesn't matter that you know it. Think about this with me. I'm not a surgeon. I don't cut people for a living. So I don't fix you by doing a surgery. In some ways, I try to help make you better by asking you to do things, right? So I ask you not to smoke cigarettes, or I ask you to take a medicine, or I ask you to do physical therapy, or I'm asking you to do something. And you may not want to do it. So it's really important that I can explain to you why I want you to do it. Why am I asking you not to smoke? Because smoking speeds up MS, and we're trying to slow the disease down, so we don't want to speed it up. And if I can help you understand why, well, then you'll do it because you understand it's important. My point here is doctors are educators. We're just trying to educate you so that you know the best course of action, or at least a course of action that we think will help you. And that's why I think it's really, really important that we remember that we're educators, and we have to be good at communicating, Because if we know the answer, or at least an answer, something that we were taught might help you, and we can't convey it to you in a way that you understand, what's the point? So I really appreciate you saying that. And it's constantly my goal to try to figure out ways of helping you understand. Many of you notice I use a lot of analogies. When I talk to you, I don't talk with numbers and letters the way that an immunologist talks to another immunologist, because that has no value to someone who's not an immunologist. I remember I used to work at a university, and my boss is this world-renowned neuroimmunologist, and he and I may have a conversation, and nobody else in the room would understand what we were talking about sometimes. And that's fine, but that's useless when talking to other people. And particularly if you are someone impacted by MS and you don't happen to be an immunologist, it doesn't make sense to use immunology, mumbo jumbo. We have to use real worlds with real people so that they understand really what we mean. So thank you for bringing that up. That's really cool. All right, I'm going to wrap up. If I didn't get to your question, don't fret. I will go through all the questions in the post, and I keep a folder of all of them, and I get to them either in live streams or I get to them in videos that I do where I just go through a bunch of questions. And as I wrap up tonight, a couple questions for you guys. Number one, I've been putting out some longer videos recently. I've been putting out videos that are over 10 minutes long. Some of them are 20 minutes long. And I would really like to know what you think of that. Is it too long? Would it be better if I chopped those videos up into little sections and released one of them a week for a couple weeks in a row? What would you guys like? Tell me. I do a video and I do a concept, and sometimes it's this long, sometimes it's this long, and my gut is to just share it, the whole thing. But I understand that sometimes it's hard to digest that. So some people could say, well, I'll just pause it, I'll come back and watch it later. Other people might like it to be in segments. So share with me what you think. Please leave a comment in the section below and let me know if these longer videos, these 12 and 20-minute videos are kind of yucky or whether you dig them. I would really like to know that. Also, again, with this format, if you like the Ask Me Anything format, what we did right now, let me know that. There's another format that I've used recently, which I also really enjoy, which is where I pick a specific topic and then I deliver a lecture on it for 30 minutes or 40 minutes, and then I answer questions about that specific topic. And my plan right now, as we do live streams, is to kind of alternate and do one and do the other style, then bounce back and forth. So let me know what you think. It is something that I do for you guys, and I want your feedback on what makes the most sense. My name's Aaron Boster, and I want to thank you guys for spending Friday night with me. I want to thank you all for your commitment to this growing online global village, and I want to thank you for your participation. I love when you watch the videos and you thumbs up the videos and you leave comments. I love reading your comments. I read all of them. Because of my job and my family, I don't always get to answer them the way that I would like to, but I really appreciate genuinely this interaction. Like I said, when I started this live stream, I didn't anticipate how much I would love this global village and how much I look forward to interacting with you. And so I want to thank you guys for that. Thank you for learning about MS with me. I will continue to make my videos. I try to put out a video about once or twice a week. I will do live streams when I'm able to. I try to do them as much as possible because I just love them. And until that next time when we see each other, God bless, take care, be the best that you can be. Have a good night.